Assalamu alaikum. Thank you. I'm going to talk about basically locally advanced or metastatic melanoma, and that's basically my topic. Whenever we see a patient with a melanoma, several questions come to the mind, and some of the question is whether how to treat this patient with a metastatic or locally advanced melanoma, or which patient should be treated, and what is the objective of the therapy? Is the disease curable or palliative? What regimen, dose, and schedule should be used, and can we personalize the therapy based on the molecular characteristic of a tumor? Now, how big is the problem melanoma? If you look at the incidence in the males, it counts fifth in terms of the incidence, and total number of cases 42,000. It's around 5% of the total incidence of the malignancy, while it is seventh in the female. Now, if you look at the incidence 2015, the incidence of most of the cancer is going down. While if you look at the melanoma, whether it's a man's or the women's, the incidence keep increasing, keep rising. But good thing is most of the disease is local disease, and most of the patients are cured with the surgical resection. About 5 to 10% of the patients do have a metastatic disease at the time of presentation. Another way to look at it is among cancer in patients under the age of 40, the incidence of melanoma is second only to that of the breast cancer in the women's and to the leukemia in men's. So this just tells you how big is the problem. As far as the mortality is concerned, there are about 46,000 cases died because of the melanoma in 2008, which increased to 48,000 in 2010, which is an increase of 5%, and there's an expectation that it may increase by 20%, by 28% by 2020, and probably it will be over 62,000. Now, if you look at all the publications up until 2010, there were more than 3,000 publications in melanoma metastatic disease, and none of the different chemotherapy regimens used showed any improvement in overall outcome. And these were the drugs which were approved in 1967. Hydroxyurea was approved by the FDA with the response rate reported 10%. Dicarbazine was approved in 1975 based on one phase 2 trial with the response rate of about 23%. The survival in general of the metastatic melanoma range 5 to 9%, 5 to 9 months, with no evidence in overall survival benefit of any treatment. If you look at the combination of chemotherapy versus single agent DTIC, the combination has better response rate comparing single agent, but again, there's no improvement in overall survival, and the combination, of course, increases the toxicity. What about the TKIs? There was a one phase 3 trial using Sorafenib with the chemotherapy, including combination of Taxol Carbo with and without Sorafenib. This was published in 2007, and as you can see, there is no improvement in overall response rate, benefit, disease-free survival, or overall survival. So there's no chemotherapy, there's no TKI which can change the outcome of the course of the patient with the metastatic melanoma. So in general, response to chemotherapy is about reported to be 10 to 20%. Combining drugs improves the response rate, but there's no evidence there's an improvement in overall survival, and of course there's an increase in the toxicity. And there's no role of second-line chemotherapy. And this was one of the quotations from Dr. Sondek, who presented in 2010 in ASCO, and he says there's no documented improvement in survival over the past 30 years. No new FDA-approved drugs for melanoma from 1992 to 2011. Until this year, first-line therapy of questionable value or supportive care. No established second-line therapy at all. No proven role of combination chemotherapy. So this is we were in just a few years ago up until 2011. Now comes there's a change. Now melanoma become the model cancer where all these saga for the immunotherapy started, and it improved the outcome. And the first thing was in 2011 came is a targeted therapy. Now basically targeted therapy that you identify a specific target on the tumor cell and you hit that target with a drug with the hope that it will control the disease. But it is not so easy because you only identify one target, but there are a lot of other underlying interconnected pathways And that's why in melanoma, none of the target therapy cure the patient. There's an improvement in survival, but none of the target therapy as of now cures the patient. Now the target which are identified most common in the melanoma is B-RAF is the most common, which is found in 40 to 50% of the cases, followed by CDK4, which is in 35%, CC and D1 20%, and CKIT in about 2 to 3%, and NRAS in about 15%. So most of the work is on this B-RAF and MEK pathways. Now basically what happened that when you block this B-RAF or MK pathway and MEK pathway, basically you control the internal stimulation of the pathways which are responsible for the growth of the tumor. So if you block them, either B-RAF alone with the dabrafenib and the vemurafenib, or in combination with trametinib or carboplatin, you try to control the tumor progression. Now, there is also an evidence patient who have a mutant B-RAF, the response to chemotherapy is much less than those who are non-mutant or wild type. The response to chemo is about 11% versus 30%. So this was one of the first trial published in 2011 which changed the look into the melanoma, the outcome of the melanoma. And this was basically vemurafenib, which is a B-RAF inhibitor, were randomized between the chemotherapy, which is dacarbazine, which is considered to be the standard of care. And this was a randomized trial. 675 patients were randomized on this trial. And the outcome, as you can see, there was an improvement of disease-free survival from 1.6 months with the chemotherapy to 6.9 months with the vemurafenib. And there was an improvement of overall survival from 9.7 months to 13.6 months. So this is the first time in over 45 years a drug has shown an improvement in overall survival about 4 months in a disease which is not responsive to any treatment. So this was the beginning of the change in the management of the melanoma. But the problem with this, when you block B-RAF, there are other pathways which stimulate the MEK pathway. And because of this, when you treat these patients, there's an increased risk of squamous cell carcinoma, which is about 26%. So when you combine the B-RAF with the MEK pathway, there's a decreased incidence of squamous cell carcinoma of the skin, and there's an improvement in disease-free and overall survival. As you can see here, this was a randomized trial combining dabrafenib with the trametinib. Disease-free survival and overall survival was improved. Similarly, with the vemurafenib and carboplatin, there was an improvement in the outcome with the combination with the decreased toxicity of especially the squamous cell carcinoma. So basically, in terms of key point for target therapy is RAF-MEK inhibitor combination approved by the FDA, including combination of dabrafenib and trametinib versus vemurafenib or carboplatin. It improved the survival, and comparing the single agent B-RAF inhibitor, there's a less skin toxicity, especially the squamous cell carcinoma, but there is other increased toxicity, especially the febrile episodes. Then come immunotherapy. Everybody is talking about it. You all know about immunotherapy now. And basically what happens in immunotherapy is you have a specific, you stimulate basically your immune system. Your immune system will take care of the cancer cells. That's the theory behind it. The drugs which were approved before 2011 were interleukin-2 and interferon. Especially interferon was approved in the adjuvant setting, and interleukin-2 was approved based on the activity on one of the trial. The overall response rate was 16%, 6% was CR, and 10% was PR, with the duration of response of 8.9 months. But the interesting finding was that 50% of the patients who responded, they have a long-term disease-free survival of 7 years, and that was one of the reasons that this drug was approved. So basically what happened that high-leukin interferon appears to be beneficial in patients, but it's very toxic. And basically when you are treating with high-dose interferon, basically you are inducing septic shock in the patient. So you need the special expertise, ICU support, and all these kind of things to treat this patient. But as a whole, there was a proof of principle that immunotherapy can change the outcome in patients with the melanoma. Then come CTL4 or cytokine T-cell lymphocyte associated antigen, which is a naturally occurring negative regulator of the immune system. And it is expressed on the T cells and the CTL, and it binds to B7 molecule, which is present on the antigen presenting cells with the high affinity to CD28, and thus stop the T cell proliferation. Now, this is just a diagram to show you that there is a on the antigen presenting cell or tumor cell, there is a B7, and on T cell there is CD28. Usually there is an interaction between these two. This interaction results in the activation of T cell. When you have CTL4, CTL4 has more affinity to B7, and when there's an interaction between these two, it inhibits the T cell activation. So if you block the CTL4 with the monoclonal antibody, which is Ipilimumab, you basically try to create the environment so you can have the interaction between the B7 and CD28. So this was one of the randomized trial in the patients who were treated previously with the chemotherapy, randomized between the Ipilimumab plus GB100. GB100 was the antigen which was proven to have some activity in the melanoma. So randomized between the combination versus single agent versus GB100 is a single agent. And as you can see, patients who receive Ipilimumab with or without GB100 have better outcome in terms of overall survival comparing GB100 single agent. What about with the chemotherapy? Comparing with the Ipilimumab, this is another phase 3 trial. Patients were randomized who were chemo naive, not treated before with the chemotherapy. 502 patients were randomized between the combination of Ipilimumab dacarbazine versus dacarbazine alone. As you can see, with the combination, the survival was much better in favor of Ipilimumab versus dacarbazine alone, 11.2 months versus 9.1 months. So this is the second evidence that if there is a drug after the targeted therapy that it shows beneficial in terms of improving the overall survival in a disease which was very fatal at one point in time. So the question is, how do you sequence in patients who have BRAF mutation? Should you give them BRAF targeted therapy first, or you should treat them with the Ipilimumab? And there was one phase 2 trial which shows that if you use BRAF inhibitor first, followed by Ipilimumab, the disease-free survival was 9.9 months. But if you change the sequence, if you use Ipilimumab first, followed by the BRAF inhibitor, the survival was improved. So just an indirect evidence that even in patients who are BRAF positive, and if they are in good performance status, the first treatment should be immunotherapy or Ipilimumab. Now, what about the role of PD-1 or the programmed cell death in patients with a melanoma? You know all this, you have seen these cartoons many times, that you have PD-1 and PD-L1 on a tumor cell. When there's an interaction, it has inhibitory signals to T cells. When you block this interaction, you stimulate the T cells, and basically you stimulate the immune system. And this is one of the phase 3 trial in patients who are Ipi refractory patients, randomized between the nivolumab 3 milligram per meter square every 2 weeks versus chemotherapy. And as you can see, this is a overall response rate was much better comparing with the chemotherapy versus Ipilimumab, 38% versus 5%. What about in patients who never received any treatment? Patients were randomized between the nivolumab versus dacarbazine, which is the standard of care, and the endpoint was overall survival, and secondary endpoint was progression-free survival. And as you can see, at 1 year, the overall survival was 70% versus 46%, and at 2 years, it was 57 versus 26%. So more than double actually at 2 years. Median survival was in favor of using the Ipilimumab as a first line. Now, what about the expression of PD-1? Any patients, whether they are negative or positive, they all benefited from the PD-1 treatment, nivolumab. Of course, those who are positive, their response was much better than those who were negative. But comparing negative or positive with the chemotherapy, they all benefited with the nivolumab. At 1 year, 70% were 46% of the patients were alive. Treatment response rate was 40% versus 14%. What about the pembrolizumab, which is another PD-1 antibody? And this was a randomized trial using in patients with epi-refractory melanoma. They were randomized between pembrolizumab 2 milligram Q3 weeks versus 10 milligram Q3 weeks versus chemotherapy. And as you can see, the response rate with the pembrolizumab, whether it's 2 milligram or 10 milligram, was better than the chemotherapy. And so is the disease-free survival, progression-free survival, 16 to 21 months versus 0.6 months. And overall survival was better, 11 versus 14 and 3.4 months. But it was not as expected, but it was still better. So there was basically no difference between the 10 milligram pembrolizumab versus 3 milligram pembrolizumab. And so that becomes the standard of care is 3 milligram per meter square. Another trial comparing pembrolizumab with the ipilimumab. And here you can see 10 milligram of pembrolizumab Q2 weeks versus Q3 weeks versus ipilimumab 3 milligram per meter square for 4 doses. And as you can see, at 12 months, it was much better in favor of pembrolizumab. So whether you use nivolumab comparing ipilimumab or whether you use pembrolizumab comparing ipilimumab, the activity of nivolumab or pembrolizumab is much better in terms of overall survival benefit and disease-free survival benefit. So the next logical question is combine these two drugs which are most active in this disease, which is PD-L1 and the CTL4, which is ipilimumab. So there was a randomized trial, about 945 patients were randomized between the combination of nivolumab plus ipilimumab versus nivo alone versus ipi alone. And as you can see, the benefit of combination was much better. The response or progression-free survival was of the combination of nivo-ipi was 11.5 months. Nivo alone was 6.9 months, while ipi alone was 2.9 months. So both these arms was better than comparing ipilimumab. Now what about the PD-1 expression, whether less than 5% or more than 5%, still there's a more response whether nivo alone or combination of nivo ipilimumab. As you can see, 54 versus 43% versus 17%. Or if it is more than 5%, then 72% and 57%, comparing to 21%. So whether it's less than 5% or more than 5%, they all respond. Of course, more is better. So approved indication for the PD-1 is nivolumab single agent 3 milligram per meter square, 3 milligram per kg Q2 weeks for unresectable metastatic melanoma with and without B-RAF mutation. In combination, there's a randomized phase 3 trial I just showed you is nivolumab 1 milligram per meter square per kg plus 3 milligram ipilimumab Q4 weeks times 4, and then nivolumab 3 milligram Q2 continue until disease progression, or single agent pembrolizumab 2 milligram per kg Q3 weeks. But of course, there is a price to pay. There is a toxicity because you are playing with the immune system. So immune system, when it is stimulated, it controls the cancer cells, but it also can damage the normal tissue. So you can have the encephalopathy, you can have a CNS symptoms, you can have an eye problem, iritis, and all this kind of things. You can have a skin toxicity. You can have the respiratory pneumonitis, which is a very grave, and you have to identify earlier in the course. Otherwise, the patient can die. You can lose the patient. You can have a hepatitis, you can have endocrine, especially hypophysitis and thyroiditis. You can have the colon colitis and diarrhea, and you can have neutropenia and all these kind of things. So you have to monitor this patient very closely for all this toxicity. Next question is there any long-term survival from any of this immunotherapy? And the answer is yes, there is. Now, this is a long-term follow-up of the patient who are treated with ipilimumab. And this is a long-term follow-up of the patient who are treated with interleukin. As you can see, with the interleukin, if you look at the tail of the curve, about 15% long-term survival with the interleukin-2. At the same time, if you look at the ipilimumab, the long-term survival is over 20%. Now, this is a follow-up of about 1,861 patients who were treated with the ipilimumab. And as you can see, the 3-year overall survival is about 22%. So patients who survive 3 years, they usually survive and they are cured. So there are about 20% of these patients can have a long-term survival in a disease which was very fatal up until before 2011. What about the long-term survival for nivolumab? As you can see, the long-term follow-up of this 4-year follow-up on this checkmate 003. As you can see, the 1-year survival is 63%, and the 4-year survival is 32%. This is nivolumab. And what about the pembrolizumab? 40% 3-year survival, and 45% for those patients who were not treated with the ipilimumab before. So what to do first? Factors to consider: BRAF status. If wild type, only immunotherapy is an option. Disease burden: if you have a BRAF mutated patient with a high disease burden on poor performance status and you need immediate response, then you should treat that with the patient with the targeted therapy as a first line. If the disease burden is low, you can start with the immunotherapy. Patient with a good performance, consider combining PD-L1 with the CTLA-4 combination. Patient in the poor performance status without BRAF mutation, consider treating them with a single agent nivolumab or PD-1. So this is where we are. We started in 1975 with a dacarbazine. Then we have interferon alpha, which it was approved as adjuvant in 1990. Then in 97 we have approval of the high-dose IL-2. Then after 2011, we have approval of all these different drugs, including Ipilimumab, Sorafenib, Sorafenib, Trametinib, pembrolizumab, and in 2016, combination of Sorafenib and Carboplatin. So where do we stand? Nivolumab is better than Ipilimumab. Yes, it is better. And the combined in the randomized trial shows median progression-free survival 6.9 versus 2.9 months. What about pembro? Is it better than Ipilimumab? Yes, it is better. In the randomized trial, 5.5 months versus 4.1 month, Q3 weeks versus Q2 weeks versus 2.8 month. Is Nivo combination with the Ipi is better than Ipi? Yes, in a randomized trial, progression-free survival 11.5 versus 2.9 month. Is Nivo plus Ipi better than Nivo? Yes, combination is better than the single agent nivolumab. Nivo then Ipi or vice versa. This was a phase 2 trial in which patients were treated in a different way, whether they receive nivolumab first or ipilimumab first. Patients who receive nivolumab first, they did better than the ipilimumab patients. What about the BRAF and MEK combination is better than BRAF alone? I showed you this combination is better. Survival 11.4 versus 7.3 month. IO before BRAF MEK combination versus BRAF. There is evidence based on the phase 2 trial that immunotherapy first is better in patients who are in good performance status, comparing the combination of BRAF and the MEK. Combining immunotherapy and BRAF MEK is the ongoing trial under evaluation. So this is where we are in 2017. Immunotherapy PD-1 inhibitor, CTLA-4 inhibitor, IL-2, they are approved. Targeted therapy, BRAF, MEK, and KIT approved. There are 10 different combinations, or all these different combinations are used. Future direction is incorporating new therapies in the adjuvant setting. Combination of all these different drugs. Management of the resistance is an issue. Sequencing therapy, how do you sequence, which one you should do first? There's no phase 3 trial, probably it will be done in the future. So in conclusion, immunotherapy can produce durable anti-tumor responses in some patients with the cancer treatment. Of patients with immune checkpoint inhibitor can be different than with the conventional therapy. There are a number of challenges, particularly resistant to the therapy, and work is in progress to combine different target therapies to overcome the resistance and prolong the survival. Now, this is just a question. If somebody wants to answer it, preferred first-line management of metastatic melanoma without BRAF mutation is close observation, ipilimumab, Sorafenib, anti-PD-1 antibody. Anybody want to answer the question? D. Good. Thank you very much.